o'clock Eastern, so I think we'll go ahead and get started. This is Liza Greenberg. I'm Interim Vice President of Quality for VNAA, and I wanted to welcome you to the Home Health Value-Based Purchasing webinar series. As you may know, our series is co-sponsored by VNAA and the Alliance for Home Health Quality and Innovation. The webinars are part of a series of technical assistance quality improvement webinars organized for the 9 states participating in the value-based payment or value-based purchasing demonstration program. And since there's very broad spread interest in value-based purchasing, the webinars are open to all organizations of interest. We had our first webinar earlier this month, which featured Chris Ataya of SHP, who covered the fundamentals of the home health value-based purchasing program. And for those of you who missed it, that webinar is available as a recording on VNAA's Learning Management System. And webinar 2, which we're here today to listen to, recognizes the importance of quality metrics in home health value-based purchasing. And we have home health value-based purchasing or value-based performance improvement 101 for you today. Next month, on March 17th at 2 o'clock, we will have Performance Improvement 102, and Margarita Labson from the Joint Commission will be presenting on customizing your QAPI for a value-based purchasing environment. So just a little bit about the sponsoring organizations. Next slide, please. The Alliance was formed in 2008 with the mission of leading and fostering research and education on the value of home health care to support patients and the entire U.S. healthcare system in driving towards quality and innovation. And VNAA is a national association that supports, promotes, and advances mission-driven home health care providers and community-based hospice organizations. So we can move forward to the next slide. I wanted to introduce our speaker, who we're very lucky to have, and the bio will be in the slides, which will be sent to you after the call today. But Barbara is Senior Advisor for the Community Healthcare Accreditation Program, also known as CHAP, which is one of VNAA's partner organizations. And CHAP is a CMS-deemed authority which accredits approximately 8,000 community-based healthcare organizations, including home health, hospice, and home medical equipment providers and pharmacy. Barbara has been with CHAP since 2013, and before that she worked as a clinician in home health care and hospice with a focus on quality. She was Corporate VP for Performance Improvement at Texas Health Resources, a multi-hospital healthcare delivery system. At THR, she led system-wide efforts to implement evidence-based practices to improve health outcomes, and she focused on preventing rehospitalizations. More recently, she served as Chief Nursing Officer for the VNAA of Texas and served on the Board of Directors for the Texas Association of Home Care and Hospice. And in 2005, she was listed as one of the Great 100 Nurses. She received a nursing degree from Texas Christian University and a Master's of Theological Studies from Bright Divinity School. We're very pleased to have Barbara with us. Thank you so much for joining us, Barbara. And just wanted to go over a couple of housekeeping notes before we get started. I did want to let you know that everyone is muted throughout the call to avoid background noise. Barbara will speak for about 40 minutes, and then we'll have questions at the end. We will be accepting questions by the chat box. You'll see that in the corner of your screen, and you can send your questions to us at any time. We will read them off and respond to as many as we can. And for any questions that are based on individual responses or that we don't get to on the call, we'll try to get back to you with a response after the call. We will be making the slides available to everyone, as well as having the webinar accessible remotely after the call. So if you have staff members or colleagues who have missed it, they can review it at their leisure after the call. And with that, I'll turn it over to Barbara. Thank you, everyone, so much for joining us. Thanks to Teresa Lee with the Alliance, Jen Schilling, and Heather Corbin for all their work pulling this together. And we look forward to hearing what Barbara has to say.
Thank you. Hello, everyone. It's true. If you look at the next slide, I am Barbara Muntz, and I am from CHAP. Although today I am not speaking to you from our headquarters in rainy, snowy, wet, cold Washington, D.C., I'm very gratefully enjoying a 70-degree day of sunshine in Dallas. I want to also say thanks to VNAA and to the Alliance for the opportunity to be with you today. We have several objectives to cover, all of which I hope will help you see that wherever you are in the value-based purchasing world, a strong, reliable, workable QAPI program is a cornerstone to your success. So we'll be talking about the basics here. This may be old hat to many of you. For others, these tools may be pieces of education that you can use with other members of your staff or your board or leadership in your organization. But we will be talking about the basics: choosing a model for conducting improvement activities, choosing measures that matter, ways to measure activities, and we'll wrap up with a visit to my friend Fran's home health agency for a case study. As Liza said earlier this month, Chris Ataya from SHP did a great job kicking off this series of webinars on value-based purchasing for home health. If you missed that initial presentation, I would encourage you to go back and look at it online. It is comprehensive and very clear about what's on the line here with value-based purchasing for home health. Basically, value-based purchasing programs, whether they are in hospitals, nursing homes, or home health, have these 4 key elements. There are standardized performance measures required. They focus on transparency and public reporting of those measures. They include innovative payment models and are built on the foundation that consumers should be able to make informed choices about their care. The goal of any value-based program is to increase the value of the healthcare, shall we say, product. This graphic that you are looking at is an old model, but I think it still holds true and is really a simple way for us to see why the move to value-based purchasing is happening. As you see here, quality plus service divided by cost equals value. So if, for the sake of illustration, you were to assign a numerical value to the items in this equation, then the higher that Q, quality, and S, service are, and the lower cost is, the higher that number value is. So, for example, if you assign a value of 3 to quality and a value of S to service, that's 3 plus 3 or 6, divide that by cost, and we can, for the sake of discussion, assign that a value of 2. So 6 divided by 2 places a value score of 3. If I push my quality and increase quality to, say, 6, from 3 to 6, and increase my service from 3 to 4, without reducing my cost, that still stays at 2, what I've got is 10 divided by 2, or a value score of 5. So you can move these numbers around and really see how working with these components can affect the value equation in your organization, which is all a very fine theory, but what does it mean for those of us in home health? Chris went into great detail about this in the last webinar, but in a nutshell, the home health value-based purchasing pilot became effective January 1st of this year. There are 9 states participating. Outcomes have been selected, and they include 10 outcome measures, 6 process measures, 5 home health CAPS measures, and 3 new measures. I think one of them is, for example, influenza vaccinations. And also an additional bullet that should be showing here is the cost implications have been determined for the pilot program. Now, here is a list of the states that are participating in the pilot that have been selected for participation. And many of you on the call are part of these states, but there are lessons to be learned for the rest of us. If any of you are golfers, or you know a golfer, or like me, you lie on the couch and take a nap in front of the TV when a golf tournament's on, then you may have heard that saying that the guy who putts second goes to school, so to speak, on the guy who putts first. So the one who's putting second is looking at the first guy to see the lay of the green, the hills and valleys, the way the grass bends, and so he is, so to speak, going to school on the first putter. And so while those of you who are in one of these 9 states, to launch the value-based purchasing pilot, the rest of us are able to watch and learn. Now, in addition to value-based purchasing, home health is looking at proposed conditions of participation that are going to change the way that we look at QAPI, at quality assurance and performance improvement. So there are some proposals out there that deal with 5 standards addressing program scope, data, activities, performance improvement projects, and the responsibilities of executives in your organization. Also, if you have looked at those proposed conditions of participation, the concepts of performance improvement are woven into many of the other standards in other sections of the proposed COPs. The proposed COPs related to performance improvement require a stronger, more integrated, and robust PI program that aligns with very well with what value-based purchasing, what aligns very well with what value-based purchasing requires for success. So if you look at these, next slide please, in a nutshell, they include the inclusion of the governing body and oversight and approval of the activities surrounding performance improvement. That old model of the PAC and the quarterly record review is evolving into something that is more proactive and forward-looking. The new COPs expect to see more projects that cover the breadth and depth and scope of and personality of what your organization is about. There are more requirements for reporting and having well-documented ongoing efforts in your performance improvement arena, and of course this last bullet, the use of data to make decisions and to take action. Basically, this is not the job of the quality nurse anymore, and that aligns very well with what value-based purchasing is all about and what they're expecting, what payers and consumers are expecting from us in terms of providing value. So what we see is we have this great convergence and alignment of efforts coming together. The value-based purchasing models, the proposed home health COP changes, we're seeing accountable care organizations, networks, narrow networks, bundling, partnerships with healthcare systems, all kinds of different ways to look at the delivery of home health care. Added to the National Quality Strategy, what we know is the triple aim, all of these things come together to create what I believe at least holds the possibility of a new era for what we are doing in home health care. And the keys to success and survival in this, so to speak, new world order lie in having a quality assurance and performance improvement program that helps you deliver on that value proposition of increased quality, increased service, and decreased cost. For starters, let's look at quality assurance and PI, performance improvement, what they are and what they aren't. They are similar, but there are differences, and I like to think of them as being 2 sides of the same coin. Both are data-driven approaches. Quality assurance tends to be a retrospective look at activities and reactive to problems. It identifies a problem and solves the problem, and it's very focused on compliance. Performance improvement, also data-driven, but more proactive and future-focused. It is built on ongoing cycles of improvement, and there is a mechanism built in so that organizations can sustain the improvements that they make over time. Both sides of the this coin are important for your success. We said at the beginning of this presentation that it's a basic level presentation, and so we are talking about the basic building blocks of performance improvement. And on the next slide, you can see some of the key aspects that support sustained success of a PI program. And those include an organization-wide commitment, team approach, data-driven decision-making, being proactive and future-focused, and continually working to improve performance. As I say, this is a 101 course, and so this may be a list of things that you already have in place and you have a strong program. On the other hand, you may need to retool some things, and this may be a good way to introduce some education to other people in your staff that need to be brought into the fold. Once again, when you look at these aspects for success of your program, this is clearly not the job of the QA nurse at the cubicle at the end of the hall. There are several standardized and widely accepted QAPI models. Each of them uses a systematic approach, uses data and information to drive decision making. They have ongoing cycles of improvement and a mechanism to sustain the gains. Your responsibility is to pick a model among the ones I'm going to show to you or others that are out there. There are many. A model that works for you and your organization, and most importantly of all, use it to build and sustain your own performance. The first model we want to look at is a basic CQI, continuous quality improvement model. You can see you begin by identifying goals and objectives and identify specific approaches you want to take with specific measurements. Once you institute those approaches and measure your performance, you share the results, tweak and make the changes necessary to provide ongoing improvement, and just keep moving forward with ongoing cycles. So you can see in this model, it is systematic, it uses data, and it is ongoing. The central idea behind Six Sigma, which is another model, is that you can measure how many defects there are in a process, and you can systematically figure out how to eliminate those defects or errors and get as close to zero defects as possible. So you can see there are systematic steps to this process. And Lean Six Sigma works very well to improve processing kinds of things. It's been used very successfully in hospitals to decrease turnaround times in hospital operations, and has some good applications in home health as well. For example, this is a great model to use to work on improving how you process orders and get them signed and back into your office, for example. So there's much to be learned from this model, and it has good applications in the home health arena. The next model is PDCA, and this is a model that's very commonly used. It's very similar, almost identical to the PDSA model, which is where I'm going to focus my discussion today. So if you take a quick look at this, and then let's just move on to the next slide, which is PDSA, just a Plan, Do, Study Act as opposed to Plan, Do, Check Act. There are 4 steps in this model. In the plan step, we identify what needs to be improved and set goals and objectives to make those improvements. The plan phase of this model requires doing some research and some study and making decisions about who's going to do what, when, and how are they going to do it. So it's basically just making a good assessment of the current state and then making a plan for what you're going to do to change to the ideal state. So in the do step, you carry out the plan as you've devised it and make note of any problems that you're running into. Identify, oh, we could do this better or that better, and as you go through the do step. Next is the study part, where you analyze the data, analyze the lessons learned in doing, and compare your accomplishments to the objectives and goals that you set for yourself. You want to summarize that information and share it with others, and then move to the act phase, which builds in that next cycle of improvement. What do we do next? How do we communicate the changes, and how do we continuously improve? So once again, this model is systematic, it's data-driven, and it has a mechanism to provide ongoing improvement. You can see that all of these models are dependent on collecting, analyzing, and acting on data. So let's talk about data. Data are the tools that we use to evaluate and improve care, to make decisions, to provide evidence of value, back to that old value proposition. And now, with value-based purchasing, data are tied to your financial well-being and tied to payment. There are 4 major types of quality measures. Process and outcome measures are the most common ones that we use. Process measures speak to doing the right thing at the right time for patients. For example, a process measure would be to look at the percentage of patients who are assessed for falls on admission, or screened for fall risk on admission. The process of screening is not the same as the outcome of a reduced fall rate. So you can think of process measures as sort of the recipe, the ingredients in the recipe that are necessary to bake the cake, but the cake is the outcome. So process measures and outcome measures are most frequently used in process improvement, but we see more and more the use of patient experience measures. And these are measures where the care is assessed and data are collected to reflect the patient's perception of care. And you are seeing that in your home health CAPS questions and those kinds of satisfaction surveys. And the 4th kind of measure is a structure measure, and these really deal with things like policies or staffing or how you do a process like on-call or those kinds of things. So the structural things that are required for good care and high value. With all these types of measures, how do you choose what to measure? Well, if you are one of the knowledgeable 9 that's in the value-based purchasing pilot program, those measures many of those measures have been selected for you. But here's some guidance that you can use to choose what other measures might matter for your organization. Focus areas range from high risk, high volume, high problem-prone areas to data that you are already collecting, such as your OASIS or your HHCAPS or information from your CASPER reports and so on and so forth, or internal trends that you identify around claims denials or incidents or accidents or those kinds of things. Any of those might be areas to mine for good performance improvement opportunities. What you want to do is choose a mix of structure, process, outcome, and patient experience measures that address the performance across your organization and will really help you tell the story of what you do and how well you do it. Some of those measures might be universal, something that I would see in no matter what home health agency I came to visit, like a rehospitalization rate. Others can and really should be unique to your organization. One more quick comment here about data. Whenever possible, it's helpful to calculate a rate. If we can look at the next slide. It's helpful to calculate a rate to report data. And this is easy to do. Simply a numerator, denominator, and then a multiplication by 100 to get a rate. For example, say you had 4 referrals this week, and 3 of those referrals were admitted to service. Well, that makes your numerator 3, your denominator 4, or do the math, and it's 75% admission rate. So very simple way to calculate a rate. And this helps to put things into context. We need rates because reporting just raw numbers does not put the information in context so that you really understand what it is that you are reviewing. For example, if you have only 4 patients and all 4 are hospitalized, you have a big problem. But if you have, as you see on the right here, 125 patients, you're doing very well and your hospitalization rate is acceptable. By calculating a rate, you put the data into a format that it can be understood and be used to identify whether or not you even really have a problem and to help you direct what next actions you need to take. Calculating rates also gives you the chance to compare with other organizations or compare yourself over time. Visuals are very helpful, and we're going to talk about run charts when we talk about Fran's Home Health Agency. Run charts enable you to look at your performance over time and really look to see whether a process is stable or not. Oftentimes we report information by the average or mean. Those are both the same things. And an average is just you add up all the numbers and divide by the number of items in a set. The median is the middle point of a number set. Most likely the median represents what is most likely to apply to any given patient. But in the world of healthcare, the use of averages or medians can really be deceptive and misleading and a problem. And the reason why is because averages don't show variances. You may think you're doing better or worse than you're really doing. Your patients don't feel averages. What they feel is variances. So if you look at this very simple graph, this is not a stable situation. The fall rate goes up and down and up and down and up and down. So although the average fall rate may not be too frightening, that's a deceptive picture, because if I'm the patient who falls and breaks my hip, I don't care one little bit that your fall rate is 3%. I care that I fell. And I don't care that you average time to return an after-hours call is 20 minutes. I care that you didn't call me back for 3 hours. So once again, patients don't feel averages. Patients feel variances. So having a PI program and choosing measures and measurement that helps you improve performance by reducing negative variation is critical for your patients' outcomes and for your success. So let's try to tie all these components together. I want to tell you the story about my friend Fran's Home Health Agency. Fran had many patients that were being readmitted to the hospital. And at the board of directors meeting, the board discussed the issue and made a commitment to help its patients stay at home and out of the hospital. The board discussed the need to reduce hospitalizations as part of the new value-based purchasing model being implemented in their states. The chair of the board asked Fran to lead a QAPI project to reduce hospitalizations over the next 9 months, and also asked her to report back to the board quarterly on her progress. All of this is recorded in the meeting minutes. Now, notice that this part of Fran's story reflects the changes in the conditions of participation, of having the board really engaged in process improvement and with regular reporting and accountability. So just last month, Fran had learned about the PDSA model, and she has adopted that to use in her agency. So she left the board of directors meeting and got to work. Just as a reminder, this is the PDSA model that Fran chose to use. So let's see how she worked the steps in the model. First, the plan phase. During this phase, Fran gathered information. She looked back at her agency's experience, and she learned that 60-day readmission rate was 19% in June of 2014. 90% of hospital readmissions were people with heart failure. 60% of readmissions occurred on the Monday or Tuesday following a Friday discharge home from the hospital, and 20% of readmissions occurred on a weekend. This may look familiar to some of you. So there are a few lessons to take from this. Note that Fran looked at her data several ways. She looked at it by diagnosis, by day of admission, by day of hospitalization, and by segmenting the data, it helped Fran to really zero in on what the root causes might be and helped her decide on what her next actions needed to be. Also, as part of the plan phase, Fran pulled together her team and they conducted a fishbone analysis. And you're all familiar with doing a fishbone diagram, I'm sure, and so we're not going to dive into that. But it did help her to further identify root causes. Here's what she learned. Here are the big takeaways from the fishbone analysis that Fran and her team conducted. They learned that new patients that were referred on Friday or discharged home on Friday were not admitted until Monday. They didn't understand their meds, they didn't understand how to get help, and they didn't understand what to eat. So by Monday, when they were seen for the first time, they were often already in trouble and had to go back to the hospital. Secondly, most heart failure patients did not weigh themselves daily, and they didn't have any PRN orders for medications if their weight was creeping. And third, heart failure patients were usually admitted with a plan of care for 2 times a week for 2 weeks and then 1 time a week for 6 weeks. And what the staff decided was that was not enough visits at the beginning of the episode of care to really learn the self-management and safety things that they needed to learn to stay out of the hospital during that critical first few days home. So once Fran really understood what the issues were, she set a goal for improvement. And this was her goal, to reduce the 60-day readmission rate from 19% to 15% by December 31st, 2015. So is Fran's goal SMART? Well, a SMART goal is specific, measurable, attainable, relevant, and time-bound, which this certainly is. So I think that she has designed a good SMART goal for her initial PI project. Note that a lot of work happened before the goal was ever set. So these activities around gathering information, analyzing it, and really finding root causes is necessary before you can decide what is a meaningful goal, what's a realistic goal, and so on. Second step is do. And here are the actions that the team committed to and what they did. They increased their weekend staffing by each RN working 1 weekend per month to conduct those admission visits and comprehensive assessments on the first day after hospital discharge. They began to see all of their heart failure patients daily ×3 at the beginning of their care, the beginning of their episode of care. Their focus during that 3 days was on teaching self-care and to avoid returns to the hospital. The office manager, so more than just clinicians involved, the office manager made daily phone calls for every day for the first 2 weeks that a patient was on service to make sure that they had weighed and what the results of the daily weigh-in was. And for each patient with heart failure, the primary nurse contacted the doctor to discuss the possibility of an order for a PRN diuretic and some parameters for giving that drug. So things we see here are data-driven decision-making. If you'll look, each one of the actions that the team took was directly tied to the most frequently identified root causes. They dealt with heart failure patients, they dealt with weekends, they dealt with front loading, and they dealt with those PRN meds and the weights. So because they thoroughly understood the problem, it helped them to make good decisions, and it helped for the team members to buy in to the many changes that they would have to make in order to pull this off. Study is the next step in the model, and so what did Fran monitor? She chose 3 process measures and 1 outcome measure for this project. The process measures were very specific. They identified what was going to be measured, how often it was going to be measured, and clearly defined what each measurement was. So they measured the percent of patients admitted to the agency on the day following their discharge from the hospital. They measured the percent of heart failure patients that were seen daily times 3 on admission, and the percent of heart failure patients that reported that they had weighed that on the days that they were called, and they wanted to hit at least 60% of those patients said yes, they measured their weight and were able to report what the weight was. And then, of course, their outcome measure is their hospitalization rate. So you can see the process measures are the ingredients of the cake, and the cake is the hospitalization rate. So how did Fran's team do? This is the study phase. Here's the first process measure. And you can see this is presented in a run chart, so Fran can see over time how her performance changed, in this case improved. And this is a helpful way to present and look at data over time, and also a good way to show your progress when you are reporting on PI activities to leaders in your organization, to board members, to interested hospitals, so on and so forth. Now, one little note is that when you're presenting these kinds of pieces of information to folks that aren't really familiar with these measures like we are, it's helpful to put a little key like the good arrow, because when someone like a board member who is basically a community business person and not a healthcare person, it's helpful to know, okay, now what's, is higher better or is lower better? So I always put these little good arrows on my charts just when I'm dealing with presenting information to folks that may not be as familiar as you are with the world of home health quality measurement. So you can see that over time, Fran was able to get those patients admitted the day after their discharge from the hospital. Now, heart failure patients seen daily times 3. This took a little while, took a little more time. Fran had to adjust her staffing, which is always challenging, and she had to get buy-in from her staff. And when you change your practice pattern, it is sometimes you meet some resistance from folks. I'm sure you have from time to time been familiar with that. So it is what happens in the real world. But with persistence, you can see that she met her target. Now, it remains to be seen whether she will sustain that target. The same way with the daily weight reporting. This took a while to ramp up and get everybody trained and to teach patients teach nurses to teach patients to expect to get a phone call about their weights and to build in that accountable system. Once again, Fran has met her target, but it remains to be seen whether she can sustain that target. And so she'll have to continue. This is great work, but she'll have to continue to work on that. And last of all, well, how did all this affect the hospitalization rate? So indeed, she has brought the hospitalization rate down. You can see the down arrow there. Good is lower. And this run chart shows us that she was able to hold that target for several months. Now, what this indicates is that perhaps Fran, as she gets into her next cycle of improvement, needs to tighten up her target and set a lower target now that she's gotten this far. So Fran continues to improve as she looks at her data and she decides to go into the next cycles of improvement. She looks for new opportunities. So one is that some of these measures that are stable, she may not need to look at every day or every week, but that doesn't mean that she's going to drop them entirely. For example, if she's measuring that a patient is weighing every day, well, once that's stable, then what she might want to do is pull a few charts from time to time and do spot checks on that to make sure that they are holding the gain that they determined they wanted to make. And sometimes that's the hardest thing to do, because as you move on to the next cycle, it's a challenge to hold on to the ground that you've already gained. Also, you want to look for new opportunities for improvement. So when Fran and her team looked at what they had accomplished for these patients, they decided they wanted to look at implementing daily ×3 visits for other patients with high-risk diagnoses like diabetes, emphysema, folks with multiple comorbidities, that kind of thing. Also, they determined that they needed to do some extra OASIS training for their weekend staff and to increase the accuracy of those comprehensive assessments. And they wanted to work with local hospitals and physician partners to encourage midweek discharge of heart failure patients. One of the things they discovered is that, you know, it's not like magic that every heart failure patient is ready to go home on a Friday. Sometimes they're ready to go home on a Wednesday. And that gives the home health agency or the next level of care sort of a head start on getting this patient education done and smooths the admission volume so that it's not craziness on Saturday admitting new patients. The next thing she did was she reported her successes to her care team and to the board of directors, and of course celebrates her team's great work. So always got to celebrate the wins and get ready for the next step in the process. So you can see that Fran has done some good work. I hope the information that's here and the case study that we've included has helped you to rethink how you might build or retool your QAPI program to improve the care you deliver, to improve your business processes, and to increase the value of your work in the eyes of your patients, partners, and payers. As I said several times, this is a beginning level course. It is not rocket science, but action is the key. So I want to leave you with a question before we turn to take your questions, and that is to really give some thought to what action will you take to ensure your success in home health's new era of value-based purchasing. And with that, I think I'll turn it back to you, Liza.
Great. Thank you so much, Barbara. That was very, very helpful in terms of laying the foundation for a quality improvement program in value-based purchasing. So we are now open for questions. You can use the chat box on your screen to send us the questions, and we will read them off and ask Barbara to address them. I guess one of the questions I have is, do you have any sense of the frequency of looking at data that agencies should shoot for, and does that change under value-based purchasing? Do you need to look at your data more frequently to manage how well you're doing on the value-based purchasing metrics?
Well, if I were in an operating an agency now, and I were in that value-based purchasing mode, or even looking forward to preparing for it, I'd be looking very carefully at those measures that have been put out there and they're pretty basic, critical sort of measures. There's no surprises, I don't think, in those measures, but I would keep a close eye on those and be able to be proactive in that, to have some way to not wait for the lag time in public reporting, but to get that information as quickly as possible so that I can act and respond where I need to make changes in my processes. The exact frequency of how often you need to look at things, I think really depends on the situation. One of the tricks is to determine what is the measure that I can look at that if I get this right, I will have gotten this and this and this and this right, if that makes sense. That there are maybe process measures that bundle together, and if I look at one piece of that, then the chances are I've gotten 4 other things right, and that sometimes can slim down the volume of things that you need to look at.
Thank you, and I think that was interesting in your example as well. So when you're reducing rehospitalizations, you're also influencing timeliness of care and some of the other elements that are also metrics in home health compare. One of the questions that has come in is, do you know when the conditions of participation will be finalized?
We at CHAP are on the edges of our seat to know the answer to that question, and we have no inside track on that. Just don't have any information that we can offer. We're all anxious to see what's going to happen. Now, I do think because the conditions of participation that are proposed around quality and performance improvement, they pretty much line up with the hospice conditions of participation in terms of the philosophy and the approach. And so we at CHAP believe that it's a pretty good bet that those conditions will move forward and be part of what the new world will look like in terms of CMS certification. And all of those components are essential building blocks for value-based purchasing, which is not going to go away. So there are things in the conditions that may or may not come true. We don't have any inside information on when they might be effective. But regardless, those components around performance improvement are really things that we need to be focused on anyway.
Okay. Thank you. And I do remind people to use the chat box for questions. Another question is, how do you balance how much effort you put into high-risk patients versus less high risk? I noticed in your segmentation of the data, you looked at it and sliced it and diced it in different ways. And people with multiple comorbidities or less help at home or racial and ethnic minorities, some of those are considered higher risk groups. How do you balance what you do for populations versus what you do for high-risk groups?
Well, I think that's a great question and a great thing to think about, because as we move into this value of healthcare, arena, there is a lot of focus on what I think Atul Gawande called the hotspotters in hospital care, where if we focus on those patients that are really high risk, we're overall going to improve the value proposition, the quality and cost, and lower our risk. I think it's interesting because one of the things I've observed, can't pull up any research to back this up, but if you think about your processes in your agency, if you focus on processes for patients with comorbidities or patients that are in a minority population or a underserved population, whatever that high-risk population is, there are things that you're going to learn and apply that are going to bleed over into your general patient population and your general care. So I think, at least for this point in our history, I think focusing on that 80-20 rule of focusing on the hot spotters, so to speak, is a good approach.
Great, thank you. Another question is, what are some of the best practices around engaging staff in your quality agenda?
Well, there are all kinds of innovative things that we've seen folks do. I think one thing is hiring folks that are committed to learning and to quality improvement. So I think that's one thing, is start back to the very beginning of am I hiring the qualities in this person that they need to have to be a part of the team? Are they team-oriented? Are they learning-oriented? And that doesn't mean they have to be data experts, but do they have the willingness to be active team participants? I think patient engagement employee engagement is tough when you have a lot of contracted employees, and many of you have those challenges of having certain disciplines that are contracted and are not part of the normal team. So finding creative ways to pull those folks in is a challenge, whether it's teleconferencing or rotating people through quality team meetings. Just-in-time training is very helpful so that you're not sitting everybody down and taking them out of operations, but doing what you need to do to get where you need to get on a specific project. So there are a lot of approaches that it is admittedly a challenge. You're not in the hospital where you can pull everybody into the conference room and for 15 minutes in the middle of the day. It's tough. But with technology and I think also really demonstrating the impact on patients' lives. One of the dramatic things, in hospital care was the 100,000 Lives campaign so many years ago. And they were able to translate actions that were taken in a hospital to how many lives were saved, and really translate out for the staff members that's X number of grandmothers that are at home for Thanksgiving dinner with their families. That, those kinds of humanizing of data to make it tell a story, the real story of the impact of these activities, I think is one way to help engage staff.
Great. That's really neat about bringing it down to the patient's lives level. I'm going to do a last call for questions via the chat box and ask one follow-up myself, which is you've mentioned sort of staff recognition a couple of times. I wonder if you have any best practices or things that you think have worked in organizations around recognizing staff who are real leaders in quality improvement.
Mm-hmm. I've seen a couple of fun things. Having visualization of projects and who was involved in that project is helpful, and that might be, I've been in agencies that have a wall of fame, so to speak, to talk about accomplishments that in performance improvement, things that have really been changed that have made things better for patients and improved outcomes, and tie that to the people and give that people, their face splashed across the bulletin board or that kind of thing. One thing that research does really show is that it's not money that motivates people. It's recognition and results. So just those simple things that we can do to recognize one another and the efforts that are made, and to do that consistently and to do it on an ongoing, frequent basis so that people sort of catch the fever and drink the Kool-Aid is really when you begin to see momentum.
Mm-hmm. Great, thank you very much. Well, on behalf of the Alliance and VNAA, I'd like to thank everyone for joining us, especially thank Barbara Muntz. You've been fantastic, really important baseline for quality improvement programs, so we do appreciate that. We will be sending out a link to the slides afterwards, and it will be available as a recording through our learning management system, and we will let you know how to access that. So again, if you have colleagues who you'd like to share this with, it will be available remotely. And on behalf of the Alliance and VNAA, once again, thank you, and we will now adjourn.